Good morning, doctors. I am Dr. Larson Taruk, and I am tasked to discuss the diseases of the oral cavity and salivary glands. The diseases of the oral cavity is divided into two groups, those affecting the soft tissues, including the salivary glands, and those involving the teeth. Diseases in the oral cavity can also be divided into neoplasia and non-neoplasia. The most common neoplasia in the oral cavity is squamous cell carcinoma. In the non-neoplasia, it includes ulceration and inflammatory lesions, proliferative lesions such as reactive or tumor-like lesions, and pre-neoplastic lesions such as leukoplakia and erythroplakia. The inflammatory lesions in the oral cavity includes aphthous ulcers, which is also known as canker sores, herpes simplex virus infections, and oral candidiasis, which is commonly known as oral thrush. Aphthous ulcer, which is commonly known as canker sores, is a common superficial mucosal ulceration affecting up to 40% of the population within the first 2 decades of life. It is extremely painful with a known cause, more prevalent within some families, and may be associated with celiac disease, inflammatory bowel disease, and Beset disease. It resolves spontaneously in 7 to 10 days without treatment, but it can recur. Grossly, it is small, less than 5 mm, round, with superficial erosion with gray to white exudates and surrounded by erythematous rim and tender. It can occur single or in groups on the non-keratinized oral mucosa on the soft palate, buccolabial mucosa, floor of the mouth, and the lateral borders of the tongue. Herpes simplex virus infection is caused by herpes simplex virus type 1 and type 2. It primarily infects children 2 to 4 years old. It is usually asymptomatic with dormant virus in the nerve ganglia and can be reactivated by trauma, allergies, UV light exposure, upper respiratory tract infection, pregnancy, menstruation, immunosuppression, and exposure to extreme temperature. Some may manifest as acute herpetic gingivostomatitis with generalized vesicles and ulceration. It is self-healing and resolved within 7 to 10 days. But sometimes antiviral agents are given. Grossly, it is solitary or multiple small vesicles containing clear fluid. Once it ruptures, a shallow and painful ulcers are seen. It is commonly located or seen on lips and nasal orifices, which is why it is known as cold sores or fever blisters. Histopathologic examination in a blister mucosa will show us a ballooned cells having a large eosinophilic intranuclear herpes simplex inclusion bodies. This one. Oral candidiasis is the most common fungal infection of the oral cavity. It is caused by Candida albicans, which is a normal flora in the oral cavity. It becomes disease when there is impaired protective mechanism in our body. This is seen in patients with diabetes, anemia, on antibiotics or glucocorticoid therapy, and in patients with immunodeficiency syndrome. Grossly, we can see a adherent white curd-like circumscribed plaque that can be easily scraped off, revealing a granular erythematous inflammatory base. Histopathologic examination will reveal a pseudohyphae superficially attached to the underlying mucosa. In summary, aphthous ulcers are painful superficial ulcers of unknown etiology that may be associated with systemic disease. Herpes simplex virus causes self-limited infection that presents with vesicles that rupture and heal without scarring and often leave latent virus in the nerve ganglia. Reactivation can occur. Oral candidiasis may occur when the oral microbiota is altered, and invasive disease may occur in immunosuppressed individuals. For the proliferative lesions of the oral cavity, this includes fibroma and pyogenic granuloma. Fibromas are submucosal nodular fibrous tissue masses. They are due to chronic irritation, which causes reactive connective tissue hyperplasia. The commonly site affected is the buccal mucosa along the bite line. The treatment is complete surgical excision and removal of the source of irritation. For pyogenic granulomas, we often see this in our clinic. They are pedunculated mass, commonly seen at the gingiva of children, young adults, and pregnant women. They are richly vascular, ulcerated with red to purple color. They grow rapidly, simulating a malignant neoplasm. However, in histopathologic examination, they are only dense proliferation of immature vessels. They can regress or mature into a dense fibrous masses or develop into a peripheral ossifying fibroma. The treatment is complete surgical excision. We proceed now to the pre-neoplastic lesions. They are the leukoplakia and erythroplakia. Leukoplakia is a whitish, well-defined mucosal patch or plaque caused by epidermal thickening or hyperkeratosis. It cannot be scraped off, and the cause is unknown. They are commonly seen in older men, aged 40 to 70 years old, and commonly involve the vermilion border of the lower lip, buccal mucosa, hard and soft palate, floor of the mouth, and other site of intraoral cavity. Grossly, they are localized or multifocal, diffuse, smooth or rough, leathery, white, discrete areas of mucosal thickening. On histology, they are variable, with hyperkeratosis without epithelial dysplasia to mild to severe dysplasia that emerges with carcinoma in situ. About 3 to 25% can undergo transformation to a squamous cell carcinoma. Thus, they must be considered as precancerous until proven histologically. On the other hand, erythroplakia is a red, velvety, granular, flat or slightly depressed mucosa with poorly defined irregular boundaries. They have much greater risk of malignancy as compared to leukoplakia, and on histology, they have marked epithelial dysplasia. The etiology are multifactorial, but tobacco use is the most common risk factor for leukoplakia and erythroplakia. This is a picture showing to us the difference between leukoplakia and erythroplakia grossly and histopathologically. In immunocompromised patients, they sometimes present with oral lesions we call hairy leukoplakia. They are white, confluent, fluffy patches on the lateral border of the tongue that cannot be scraped off. They are caused by EBV or Epstein-Barr virus, and the good thing about this lesion is that they are not a pre-malignant condition. This is a table showing to us the different systemic disease, be it infectious disease or hematologic disorder, that can present with oral lesions. Dental caries are due to food degradation of tooth structure, most common cause of tooth loss before age 35, and this is due to bacterial fermentation of sugar from carbohydrate, resulting to the formation of acid metabolic end products, which will eventually lead to mineral dissolution of tooth structure. Prevention is good oral hygiene and increased fluoride intake or use of fluoride-containing toothpaste. For gingivitis, we have to define first what is a gingiva. This is a squamous mucosa in between the teeth and around them. So the inflammation of gingiva is what we call as gingivitis. This is due to lack of proper oral hygiene, which can lead to accumulation of dental plaque and calculus. A dental plaque is a sticky, colorless biofilm that builds in between and on the surface of the teeth. The components of dental plaque are oral bacteria, proteins from oral saliva, and desquamated epithelial cells. These plaques become mineralized to form calculus. Bacteria in the plaque release acids from sugar, which eventually erode enamel surface and causes dental caries. Plaque build-up beneath the gum line causes gingivitis, which present with gingival erythema, edema, bleeding, changes in contour, loss of tissue adaptation to teeth. This is a reversible disease with the treatment of reducing accumulation of plaque and calculus via brushing, flossing, and regular dental visits. Periodontitis is an inflammatory process affecting the supporting structure of the teeth, namely the periodontal ligaments, alveolar bone, and cementum. Periodontitis may cause complete destruction of periodontal ligament and alveolar bone, resulting to the loss of attachment of teeth. Periodontitis is due to the poor oral hygiene, which eventually shift in the types and proportion of bacteria along the gingiva. They can also be associated with several systemic diseases such as AIDS, leukemia, Crohn's disease, diabetes mellitus, Down syndrome, sarcoidosis, and syndrome associated with polymorphonuclear defects. They can also be an etiologic factor for systemic diseases, such as infective endocarditis, pulmonary and brain abscess, and adverse pregnancy outcome. We now proceed to the neoplastic lesion of the oral cavity, which is oral squamous cell carcinoma. Squamous cell carcinoma is the most common cancer of the oral cavity. It commonly affects 40 years old and above. Risk factors are tobacco use, alcohol abuse, and human papillomavirus type 16 and 18. The pathogenesis for chronic alcohol and tobacco users in the development of squamous cell carcinoma is due to the exposure to carcinogens resulting to gene mutation and proliferation of cancer cells. While for infection by oncogenic variants of HPV, it causes overexpression of P16, eventually resulting to unregulated proliferation of cancer cells. Clinically, patients may complain of local pain or difficulty in chewing, but sometimes they may be asymptomatic. The common sites of involvement are the ventral surface of the tongue, floor of the mouth, lower lip, soft palate, and gingiva. Grossly, a patient with squamous cell carcinoma in the oral cavity will have a picture of a raised, firm, pearly plaque or irregular, rough, or verrucous mucosal thickening, just as shown in the picture. On histology, there is a dysplastic squamous cells infiltrating the underlying connective tissue stroma. In summary, fibromas and pyogenic granulomas are common reactive lesions of the oral mucosa. Leukoplakias are mucosal plaques that may undergo malignant transformation. The risk of malignant transformation is greater in erythroplakia. A majority of oral cavity cancers are squamous cell carcinomas. Oral squamous cell carcinomas are classically linked to tobacco and alcohol use, but the incidence of HPV-associated lesions is rising. We now proceed to the salivary gland diseases. Salivary gland diseases is divided into neoplasia and non-neoplasia. Non-neoplasia includes xerostomia and sialadenitis, while neoplasia includes benign and malignant. Xerostomia, or dry mouth, is due to the decreased production of saliva. There are several causes, namely autoimmune syndrome, radiation therapy, treatment with anticholinergic, antidepressant or antipsychotic, diuretic, antihypertensive, sedative, muscle relaxant, and antihistamine. Sialadenitis is caused by trauma, viral, bacterial, or autoimmune. In trauma, there is formation of mucocele, which is due to the blockage or rupture of salivary gland duct with consequent leakage of saliva into the surrounding tissue. There may be fluctuant swelling of the lower lip. For viral, the causes are mumps, paramyxovirus, influenza, and parainfluenza viruses. For bacterial, the causes are Staphylococcus aureus and Streptococcus viridans. Often, it is secondary to ductal obstruction resulting from stone formation. Autoimmune diseases can cause chronic sialadenitis. This is due to the decreased production of saliva and subsequent inflammation. We now proceed to salivary gland neoplasia. It often affects the parotid gland. Most are benign, but as the size of the gland decreases, the risk of malignancy increases. Meaning to say, minor salivary gland has higher chances of having a malignant type of neoplasia. The most common benign neoplasia in the salivary gland is pleomorphic adenoma. And the most common malignant tumor in the salivary gland is mucoepidermoid carcinoma. They usually occurs in adults with female predominance, presenting with a swelling about 4 to 6 centimeters and mobile on palpation. The following are the different benign and malignant type of salivary gland. As what I have said, for the benign, the most common is pleomorphic adenoma, and for the malignant is mucoepidermoid carcinoma. Pleomorphic adenoma is a common benign neoplasm in the parotid gland. It is painless, slow-growing, and mobile mass. Grossly, it is rounded, well-demarcated, and encapsulated mass. Microscopically, it has a mixture of both epithelial and mesenchymal components. The treatment is complete excision. Mucoepidermoid carcinoma is the most common form of malignant tumor of the salivary glands. Grossly, it is circumscribed, lac capsule with infiltrative border. Microscopically, it has a mixture of squamous cells, mucus-secreting cells, and intermediate cells. Mucoepidermoid carcinoma is subclassified based on histology as low, intermediate, or high-grade tumor. These are the other tumors in the salivary gland, namely the Warthin tumor, acinic cell carcinoma, and adenoid cystic carcinoma. In summary, sialadenitis can be caused by trauma, infection, or an autoimmune reaction. Pleomorphic adenoma is a slow-growing neoplasm composed of a heterogeneous mixture of epithelial and mesenchymal cells. Mucoepidermoid carcinoma is a malignant neoplasm of variable biologic aggressiveness that is composed of a mixture of squamous and mucous cells. Thank you for listening